So we'd like to thank you very much for coming this evening. We both feel very privileged to work with the folks that we work with in the Substance Use and Concurrent Disorders program, and we're very much excited to speak with you folks today about some of the things about the work that we do, talk a bit about substance use disorders, what do they look like, what do concurrent disorders look like, what does treatment look like, and hopefully demystify a few things for you. What we're hoping to cover today is we're going to talk a little bit about what are the signs and symptoms of a substance use disorder. We'd like to discuss the overlap between substance use and mental health difficulties. What does that look like? Talk about the types of treatment and also ways of accessing treatment. That's kind of the overview of what we hope to talk about today. But before we get to that, I just want to throw out some stats for you folks, and just to contextualize our topic a little bit more. This $38.4 billion, this is the societal cost of substance use in Canada. So if we think about that on a per person basis, that's about $1,100 costs every Canadian, regardless of age, a year for costs related to substance use difficulties. And these costs can be divided in different categories. So some of them might involve lost productivity costs, some of them might involve healthcare costs, some of them might involve criminal justice system costs, and then there's other sort of extraneous costs like research and prevention and property damage, workplace costs that don't fall into kind of the lost productivity domain. So it's a lot of money each year. And if we look at the costs of alcohol, opioids, and cannabis, and these are our kind of largest substances in addition to tobacco for costs. So if we look back at this number, about 70% of this number is related to tobacco and alcohol use. About 9% is opioids, and then 7% is cannabis. That's sort of the breakdown there. So if we look at days in hospital and also costs, with opioids, alcohol, and cannabis, we notice that these costs are rising over time. They're not going down, they're rising over time. We're also realizing as well, and this is in the news, there was a newspaper article in The Sun today about the number of deaths in 2018, but the costs of opioids, the death rates for opioids, this is Ontario statistics, are rising at an incredible rate. And the reason that I'm talking a bit more about these statistics are to really show that the harms of substance use are increasing. There are many people that are affected by this, and we need to think about substance use on multiple different levels. So we're psychologists, we talk a lot about treatment of individuals with substance use, but we also need to really be thinking about families, we need to be thinking about communities, we need to be thinking about policies and procedures. There's lots of different ways to help out here, and we all could be doing a lot more. So it's important to think about throughout this talk too, helping the individual, but also what are the different ways that we can be a part of the solution here. So with that, I'm going to turn it over to Dr. Aries, who's going to talk a bit more about different types of substances.
Hi, so this might be your more kind of educational didactic piece where I'm talking about what different substances are. So I'm just going to classify them as depressants, stimulants, and hallucinogens. In the class of depressants, what you have are substances that kind of reduce your central nervous system, which kind of helps control heart rate, your breathing, your blood pressure, and so on. So here you'll have things like alcohol, benzodiazepines, which are things like Valium and Xanax and clonazepam, usually prescribed drugs, and opioids, which kind of belong to that category of painkillers. Things like OxyContin, hydromorphone, fentanyl will kind of fall into that category. Stimulants kind of have the opposite effect, where they increase your heart rate, your blood pressure, your breathing. And here you have cocaine, crack cocaine, amphetamines. And in this category, you can kind of lump in things like methamphetamines, crystal meth, speed, and so on. So these kind of These would be kind of your stimulant category. And we also have prescription medications here, prescription medications for attention deficit and hyperactivity disorder, like Adderall or Ritalin or Vyvanse. And then our hallucinogens, cannabis, so marijuana, which is a hallucinogen, but it has other properties as well, and LSD, which is kind of like acid or hallucinogenic mushrooms and so on. So I'm really going to focus on two main substances in this kind of introductory section, alcohol and cannabis, because these are the two substances that tend to be most commonly used in Canada. And I think an important part to figuring out whether or not you have a substance use disorder is we kind of need to quantify things. And this is how we quantify alcohol. These are what we call a standard drink, because it can be very confusing, right? You have tall cans of beers and small cans of beers, and you have mixed drinks with multiple shots. So essentially, one standard drink is 12 ounces of beer, 12 ounces of cider cooler, 5 ounces of wine, or 1.5 ounces of a hard liquor like vodka, rum, gin, right? So that kind of puts things into perspective a little bit. And a lot of research has gone into figuring out, well, what are the short-term effects, the risks of alcohol use, and what are the long-term health effects of alcohol use? And essentially, we've come up with some guidelines. So Health Canada has come up with some guidelines. And when we want to reduce the long-term health effects of alcohol use, and these would be things like increasing your risk of developing cancer or liver disease, when it comes down to it, for women, you want to have no more than 10 drinks a week, with really no more than 2 drinks a day on any given day. And for men, it's 15 drinks a week, right, with no more than 3 drinks a day. And the idea is to plan non-drinking days as well, because you really don't want to form a habit. And it's important to note that these guidelines are for individuals aged 25 to 65. So for people who fall in the younger category or the older category, the effects of alcohol can be even more pronounced. And so the guidelines would be different for these groups. And then there's the acute risks. So the immediate risks to a person's safety, for example, driving under the influence or getting into an accident, injury, and so forth. And so here we're really talking about binge drinking. So when people binge drink, then they're more at risk of something acute happening to them. And here, a binge for men is 5 or more drinks, and for a woman, it's 4 or more drinks. And so if you want to reduce your risk of your acute risks, then you'd really want to keep it to 3 drinks for a woman and 4 drinks for a man. So how much do Canadians drink? I don't know. I always wondered about this. So there's the Canadian Tobacco and Alcohol Drug Survey, and they kind of do this survey, year after year. And this is the most recent data from 2017. And it shows that on average, or that 78% of Canadians had alcohol in the past year once. So that's not super interesting. But when we break it down, here we have about the first on the left side is the chronic risk guidelines, which means that these folks here exceed your 10 drinks a week for women and your 15 drinks a week for men. So in the youth between 15 and 19, about 18% of our Canadian youth exceed the chronic risk guidelines. 29 of our young adults, right, 20 to 24. So here you're thinking university age, it's kind of a bit more normative for people to be using. And 20% of adults exceed the chronic risk guidelines. And when we look at the acute risks, so here it would be, binge drinking essentially. 12% of youth binge drink, 24% of adults aged 20 to 24, and 14% of adults, right? So it just kind of gives you a bit of context. So you might be wondering how you're drinking, how your loved one's drinking kind of fares compared to these statistics. There's actually this neat website here that you can visit, and you can kind of type in your information, how often you drink, and so on, and what are the consequences of your use. And it compares you to other people. I think this one's in Ontario, but it compares you to other people, and you can kind of see where your drinking is relative to other people, right? It's nice to know. So cannabis is kind of unlike alcohol. So we have these very kind of straightforward guidelines for alcohol. We have the one standard drink, and that's pretty clear, pretty straightforward. With cannabis, there's different concentrations of THC and CBD, and there's edibles and oils, and we don't have guidelines when it comes to precise amounts that are kind of safer to use. What we have are more guidelines to make your use safer, right? So for example, don't smoke cannabis while you're driving a vehicle, or after smoking cannabis, don't drive a vehicle. And maybe, keep your cannabis smoking to like once or twice a week, but we don't have specific quantities associated with those guidelines like we do for alcohol. So how much do Canadians smoke cannabis? So again, the Canadian Tobacco and Alcohol and Drug Survey, in the past year, I think it was 15% of Canadians smoked cannabis at least once in the past year. And if you break it down, that's the general population. Youth, about 19% smoked it or used cannabis. Then you have your young adults and your older, over 25 adults. And of those who used in the past year, most used in the past 3 months. And of those who use in the past 3 months, 32% use on a daily or near daily basis. So it just kind of puts things into perspective for you a little bit. So what about other substances, right? We talked about alcohol and cannabis. These next ones are kind of lumped into categories, but here we have all of our illicit drugs. So in Canada, about 3% of Canadians use things like cocaine and ecstasy and speed and methamphetamine and hallucinogens and heroin in the past year. And when it comes to prescription medication used for recreational purposes, so not for medical purposes, 5% of Canadians use prescription opioids, stimulants, or sedatives in the past year. So how do you know if you have a substance use problem, or how do you know if your loved one has a substance use problem? So this is the quick and dirty rule, and then we'll get into a more kind of detailed rule. But the 4 C's of addiction, right? If you notice that they have a lot of cravings to use substances, if they've lost control over their use, if they use despite consequences, so despite consequences to their work, to their relationships, despite the financial consequences of their use. But I'm going to be a bit more specific. So here we're going to look at the DSM-5 criteria, and that's the Diagnostic and Statistical Manual of Mental Health Disorders. And we have a total of 18 criteria, but you only need to kind of meet 2 to qualify for a mild substance use disorder. So this is our impaired control category, where you use more than you intended. You really want to cut down, but it's kind of hard for you to cut down. You keep on having unsuccessful efforts to cut down. You devote a lot of time to using the substances, to recovering from the substances, and you have cravings. Our second set of criteria is more the social impairment, so how it impacts your roles and the things that you do. So you can't fulfill your major role obligations like going to work or parenting. You continue to use despite all these problems, to your relationship, financial problems, and so on. And you might reduce or stop important activities as a result of your use. Your use really kind of takes over. Risky use is really using in situations that are physically hazardous. So for example, drinking and driving, or using despite physical and psychological consequences. So this might be someone who has chronic health problems, whose substance use exacerbates their chronic health problems, right? Or someone who has mental health problems whose substance use makes it worse. So for example, someone who has depression or someone who uses alcohol, and the alcohol just makes that depression worse, right? And then it just becomes more problematic. And this last criteria is the pharmacological criteria. And this has to do with building a tolerance. So you need more of the substance to have the same effect, or the same amount just doesn't have the same effect as it used to. And then the withdrawal criteria, which has to do with your withdrawal symptoms associated with different substances, or using so that you don't experience withdrawal symptoms, right? So people will have that eye opener in the morning. That would be a way of kind of staving off those withdrawal symptoms. Substance use disorders need to cause distress and impairment. So that's how you would know whether or not based on the criteria in this, whether or not someone has a substance use disorder. And it operates on a continuum. So in mild, you would have 2 or 3 of those symptoms, in moderate 4 to 5, and in severe 6 or more. How does one develop a substance use disorder? And I think it's really important to highlight here that anyone can develop a substance use disorder, but some people are a bit more vulnerable, but we kind of all are, like all our brains are vulnerable to, developing a substance use disorder if you keep on repeating the use of a substance. So one would be having a vulnerable host, right? So that's the person maybe having a family history of substance use problems, or maybe having psychiatric problems that make them more vulnerable to developing a substance use disorder. Growing up in the right or wrong environment, right? So histories of childhood abuse, parents who use substances who kind of model that behavior, your peer group, right? Especially substance use disorders tend to develop in childhood and adolescence when your peer group becomes very important and influential. I think that's about it. And then repeated use. So the more someone uses a substance, the more it kind of affects your brain. It affects 2 really important parts of your brain. One of them is what we call the reward system. So it makes it harder for people to feel joy without the use of substances. And the other part is your prefrontal cortex. So people have a harder time controlling impulses, controlling their use, because the part of your brain that kind of does that doesn't work as well as people continue to use. But these things do get better when you stop using. And what is a concurrent disorder? So really it is when someone has a substance use disorder and a mental health problem, and we call that a concurrent disorder. Concurrent disorders are the norm. So people with substance use problems have higher rates of mental health problems than the general population. And the reverse is also true. People with mental health problems have higher rates of substance use problems than the general population. And unfortunately, the group that is most vulnerable are young adults aged 15 to 24 that are more likely to have concurrent disorders, and they tend to be more severe. And this is just some more stats for you. But here we have essentially 40% of people with a substance use problem have a co-occurring mental health illness at some point in their lifetime. And about 11% of people with substance use problems have a severe mental health problem. So that would be something like bipolar or schizophrenia. And here's the reverse. People with mental health illnesses tend to have substance use problems and so on. So it's really more the norm than it is the exception. But we do need to distinguish a little bit between substance use problems and mental health problems, because the tricky thing about substances is that they can kind of mimic different disorders. So most of our substances can mimic most of our mental health conditions, either while they're intoxicated or in the withdrawal period. So as you see here, the I stands for intoxication and the W for withdrawal. And you could tell that for most of these substances, it could look like a psychotic illness. It could look like a bipolar disorder, depressive disorder, an anxiety disorder. So if you're wondering if someone has mental health problems and they're also using substances, it's possible that their substance use is kind of causing those symptoms. It's also possible that they can have a concurrent disorder. So which one came first, the chicken or the egg, right? The substance use or the mental health problem? There are many models, many possible models. One of them is when the substance use happens first. So for example, Joe is smoking a lot of marijuana, stopped working, and is spending a lot of time in his basement. Joe develops depression, right? Or someone is using a lot of marijuana in their adolescence, and that might put them at risk of developing a psychotic illness. Sometimes someone has a mental illness that then brings on a substance use problem. So in this example, it could be someone has social anxiety, and the only way that they can feel comfortable around people is to drink or use drugs. And then now they have a substance use problem if they kind of continue using that coping strategy over time. Sometimes a common factor can cause both, right? So if someone grows up in a very kind of chaotic, difficult home environment where maybe they're exposed to substances, they might cope with that environment by using, and they might also develop a mental health problem as a result of that. And finally, we have our bidirectional Oops model. got a little eager there. Where let's say someone got into a car accident and it's very traumatic, and one of the ways that they're coping with the trauma of being in a car accident is to use substances, and then that develops into two different problems. So I'll pass the floor to Dr. Bell here, who will talk about how important it is to find treatment that integrates both substance use and mental health, and not to focus on one to the exclusion of the other.
All right, so we're going to shift gears a little bit and talk a bit about what does treatment look like for folks with substance use and mental health difficulties. Thank you. Before I came into this field and started working with folks with substance use and concurrent mental health difficulties, this is kind of the archetype of what treatment was posed as looking like for helping with substance use. So it's kind of like this mansion in the woods. There's awesome foliage, there's lakes, it's beautiful, it's an awesome place. It's like this utopian society where, people go, they stay for, a month, 3 months, a year, some sort of magic wizardry happens, people come out, and then people have no difficulties with substance use, right? So that's kind of the frame that was kind of posed out there. And, this is something that's incredibly detrimental to folks with substance use difficulties, to the communities, to families, to from a general perspective, because if we think about this, using this metaphor for, say, physical health, this is kind of like saying, well, I'm going to go to a gym for the next month. I'm going to work out there. I'm going to live there. I'm going to, get buff as heck. And then I'm going to leave the gym, and then I'm going to have to do nothing else. Healthy eating, I don't have to walk up a stair ever again in my life. So, that would be awesome, but it's not realistic. It's not what happens. So it's very important to consider treatment as an ongoing process for folks with mental health, with substance use. It doesn't just happen in this magical castle in the woods. It doesn't end in treatment. It's something that's an ongoing process that can have many peaks and valleys along the way. So really, treatment is multifaceted. It can look very different for very different people, and just because you're not in a castle in the woods, that doesn't mean that the treatment's not going to work for you. So I'm going to talk a little bit about general approaches to treatment, and then some examples of what treatment can look like for people. If we think about sort of general approaches to treating folks with concurrent disorders, so both substance use and mental health, one general treatment approach is treating the substance use and the mental health difficulties at the same place at the same time. And so this would be considered the gold standard of care, where people are getting the services that they need at one location. They're not having to sort of run all over the place. The next best would be parallel. So this would be where folks are getting substance use treatment in one place or with one practitioner of some sort, and then mental health treatment from another place, from another mental health practitioner. So say, for example, going to a physician to pick up the Suboxone and talk about sort of antidepressant medications or other mental health related medications, and then potentially going to a psychologist or a counselor or whatnot to work on depression, that kind of stuff. So same time, but different providers, different places. The least advantageous form or sort of structured treatment would be sequential, where this is sort of like ping pong effect, where people bounce back and forth and back and forth and back and forth. So this is treating the substance use and the mental health stuff, picking one first and then treating the other. So that's kind of where people get into this sort of cycle of, oh yeah, no, you come back to me when you fixed your substance use difficulties, and then I'll help you with your depression. But as we just saw a few slides ago, everything is very strongly connected, so it doesn't work out very well. So we know that from the evidence that the integrated care, where people get services, same place, substance use and mental health, same time, that's the best standard of care. Now, thinking a bit more about different components of like, what does treatment look like? What do people do? Does magic wizardry happen? Medications can be a very important component of treatment for mental health or substance use. Some examples of this would be opioid agonist therapy. So for folks with a opioid use disorder in the moderate to severe range, that would be the gold standard of care. So that's when people are talking about buprenorphine, naloxone, or Suboxone, or methadone. So there's not a lot of evidence for, doing other psychosocial type treatments for folks with moderate to severe opioid use disorder if you don't have this in place. Other examples could be stuff like naltrexone, which is an anti-craving medication, nicotine replacement therapy, antidepressants, mood stabilizers. So medications could be a very important component of care. Other psychosocial treatments, and this is where psychology comes in a lot, with working directly with clients, training other folks to work with clients, providing consultation and sort of developing treatments and evaluating treatments. There's a bunch of different psychosocial treatments that can come into play here, and I'm just going to give a brief description of all of them. You could spend hours and hours on each of these, but I'll try and do this in under 4 minutes. So motivational interviewing is talking to folks about change. So some people are very much gung-ho. I'm gonna stop using substances. I'm gonna reduce my substance use. Then we're kind of helping folks set goals along that way. Sometimes folks are like, hey, I'm kind of on the fence. Part of me wants to do this. Part of me doesn't want to do this. So motivational interviewing is also helping with working with ambivalence. Or if people are like, nope, not interested in this, it's also, finding other goals to work on first, and then maybe coming back to substance use and other mental health goals. Harm reduction is, I guess I kind of liken this to substance use first aid, regardless of what your substance use goals are, if they're abstinence, if they're reducing substance use, if they're using safer. Harm reduction lessens the harms of using substances. And if we go back to the slide way time ago where it was 38.4 billion, harm reduction can help the individual, it can help society, can help families, and lots of different levels of perspective here. So it's another strong evidence-based intervention for substance use. Cognitive behavior therapy. Some people may have heard some of these terms before, some people may not. It's basically looking at the connections between people's thoughts, feelings, behaviors, physical sensations, and looking at how our interpretations really affect how we feel about something. Some people might be like, if they get 50% on an exam, oh crap, I suck. As where other people might be like, yay, I passed, I don't have to think about that anymore, right? So, which was me in some exams, but anyway. So it's really looking at our interpretations and how we can kind of question our thoughts and see if they actually match the situation. And that can have great effects for our, emotions and our behaviors and substance use patterns as well. There's dialectical behavior therapy, where it's more kind of concrete strategies in the moment for managing really distressing emotions, surviving situations without making them worse, or potentially, using to cope with that situation. It talks about kind of managing different emotions, communication strategies, mindfulness to some extent. So that's dialectical behavior therapy. There's family-focused approaches where we bring in the family members as well. There's a lot of evidence behind that. So we're not just working with, the individual with substance use difficulties and mental health difficulties. We're trying to also create change within the system around the person. There's contingency management as well, which this is basically like rewarding behaviors. So we know as part of the criteria for substance use disorder that people use despite negative consequences. So punishment and that type of thing, it doesn't work out very well. Contingency management is about rewarding positive behaviors, rewarding behaviors that are moving towards your goals. And then with all of these, what's really important is to consider psychosocial support. So what do people's housing look like? What do people's financial situation look like? What do people's relationship look like? Because if these things aren't going so well either, you're not necessarily going to be wanting to sit down and talk about your thoughts, right? It's like, no, I actually need a house right now. I need a place to sleep tonight. So that's very integral in care as well. Then if we think about with all those components, there are different categories of treatment. There are different intensities of treatment that people can go into. And these can be made up of one or more of the components that I talked about, plus some additional ones as well. So often what people think of when they think about substance use difficulties and treatment is peer support groups. So it's like, oh, someone has difficulties with alcohol, go to AA or Alcoholics Anonymous or Narcotics Anonymous or Smart Recovery or those types of groups. So peer support is a large group, and it can be a huge component to people's care. It can be all of people's care. People can be be helpful with that. And then there's also other groups like Psychiatric Survivors of Ottawa, which provide a lot of peer facilitated groups for both mental health, substance use, and leisure groups as well. So there's a variety of different dimensions of peer support. Residential is, again, it could be a castle in the woods. There are ones that exist, but those are very expensive castles to go to, and they, some residential treatment programs are fee for service. There's different ones that target different things. So some are more just targeting substance use difficulties. Some are more targeting mental health and substance use difficulties. There's different skill mixes of folks, and there's different lengths of time that people can go to work on substance use difficulties within a residential facility. Another category of treatment that people often think about is family support. So within the Alcoholics Anonymous type group format, there are groups for family support. So for folks with loved ones who have substance use difficulties, trying to figure out ways of supporting them. There's also Rideau Wood in Ottawa, and also Serenity Renewal. I'm going to be listing off a bunch of resources. Don't worry, you don't have to write them all down. We'll have a place that you can, we'll talk about how to access these services in a minute. But there's lots of different family support groups. Then inpatient is, these are the folks who have potentially more complex concerns and need, for example, medical management of withdrawal symptoms. So these are the folks who need to be admitted to a hospital, say they're withdrawing from alcohol use, which could be very dangerous withdrawal pattern, and they might need medication in order to help them with that. They might need more intensive treatment. They could be different physical difficulties or mental health difficulties that are getting in the way of people being able to go to treatment back and forth every day. So this is for the most intense kind of level of care. And then there's outpatient, where you might still be associated with a hospital of some sort, but people might be participating in a day program, or kind of coming in to see a psychologist or a physician or a social worker to help with housing related concerns, or pick up their Suboxone. So there's different options along that point. And then there's community-based care too. So that, Canadian Mental Health Association, they have a lot of groups. This could be going to Ottawa Public Health to pick up harm reduction supplies. There's lots of different avenues that people can access treatment, and different things work for different people. It's not a one-size-fits-all strategy, and you can kind of work through different combinations of these things as well. You might start off as an inpatient and then go to outpatient, and then you're good with peer support after that. Or you might start off with peer support, then go to inpatient. So people can go back and forth through this system. And this is just a bit of an overview of the different services that we provide at the Royal. I'm not going to go into a massive amount of detail, but these kind of hit a bunch of the different levels that I just talked about. So we have withdrawal management services where we have our outpatient regional opioid intervention service, or ROIS for short, that targets folks who are 16 years of age or older, and these folks largely try and target young adults, and these folks have difficulties with opioids and also concurrent mental health difficulties. We have our outpatient rapid access addiction medicine clinic for opioids and alcohol, which is called a RAM clinic for short, because all these things are very long to say. And so this is where people can walk in and get same-day care for alcohol and opioids. We also have partnerships with a variety of the other hospitals in the area. We have inpatient medical withdrawal management unit, which is our assessment unit, ASU, which is for medically assisted withdrawal management for alcohol and opioids. We also have our Concurrent Disorders unit, where Dr. Ayres and I mostly work. We have a 12-bed inpatient unit where we offer intensive treatment. People have their own care teams, mini care team within the broader care team, and we have lots of groups. We try and target all the things that I just talked about in terms of psychosocial interventions and also medical interventions. Then our day program is sort of stems out of that, where people can get the same access to the team, same programming, but people don't sleep here during the night. Also, our on the Concurrent Disorders unit, people go home on weekends, so people have a chance to test out some of these skills over the weekend. Then we have our Transitional Age Youth Service, which comes out of Carlingwood, and they focus on youth 16 to 25 with concurrent disorders. And the other services we have are outreach and also early intervention program, which goes into schools. So that's just a little bit of a rundown. And then, if we think about what makes people go into one service or another. One of the things is severity of use. How much are people using? What are people using? Do people need medical assisting in their withdrawal management? What are people's level of functioning, and also current commitments? Like, do people have kids? Do people have jobs that they want to go to? Do people have other people that they have to care for? What is the context that people live in? So, sometimes residential treatment, inpatient, that's not an option for folks because, they have other stuff that they need to do each day. We're looking at personal resources. Do people have the finances to potentially, engage in some fee-for-service care, or maybe people do not? What are people able to do? Location, what's transportation look like for folks? Can you go out to Orleans to get service if you live in Smith Falls? Do people have a car? Also, it kind of fits within this next one, what are people's comorbid mental health and physical health difficulties? If we're looking at, say, residential treatment and there's a lot of stairs, is that a good option for folks? So there's lots of different considerations about, what matches people to their level of treatment. And it's very important to match people to the level of treatment that they need. Now, how do we access this stuff? And, I just listed off a number of different kind of treatment options and listed off different types of treatment institutions. This is a really important phone number for people to have. So this is our service access to recovery, not R as in the Royal Service, this is service access to recovery. It's previously called ORS. And in the Champlain-Lynn, this is our systems navigator. So if you have questions about, where to go, where to find services, these are the people to call. So they provide navigation for services within the Champlain-Lynn. They triage folks, and they provide a bit of an assessment as well, and then referral to treatment. So they directly refer folks to treatment. So, sorry? They're abolishing the LHIN, but so these guys still have the best one of the best knowledges about what services are available within Ottawa and the greater area of Ottawa. So we can replace it with that soon. And they also refer you directly to treatment. So instead of sort of trying to remember a list of all these different places, contact these guys. These guys are really important. Public Health Ottawa, or Ottawa Public Health, also has a list of resources for harm reduction and also treatment services for mental health. They're an awesome resource. And then I'll turn it over to Dr. Aries for the take-home messages.
I was getting a bit too comfortable in my chair there. So yes, the take-home messages of our presentation is not everyone who uses substances has a substance use disorder. So it's important to think about those 4 C's of addiction or the DSM-5 criteria to see if it actually is a problem for them. Concurrent substance use and mental health disorders are the norm, not the exception. As Dr. Bell spoke about, integrated treatment is the gold standard of care. It's really important to treat both the substance use and the mental health problems concurrently for the best outcomes. And there are many ways that we can access treatment. It's not that one castle in the woods, right? Or the residential treatment that people seem to think that 28 days and I'm going to be fixed, right? There are many different ways of accessing treatment, many different treatment options that can be really well suited to the person. And ultimately, it's really important to match the treatment to the individual's needs, because not everyone needs a 28-day residential treatment, right? Some people do really, really well in outpatient care. Some people need inpatient care, right? It's important to match the treatment to their needs. So I believe we're wrapping it up, and we'll be taking some questions.